As you all know, I am Dr. Sunita Ahlawat. I am the principal consultant histopathologist at SRL FMRI Gurugram. And today's talk and the series of these lecture is courtesy my friend Dr. Priya Tiwari. She requested me that I take classes for her DNP students. And then we thought that, you know, we extend the benefit to whosoever is willing to spend Saturday and Sunday night with us. So we decided to cover the new WHO classification 2021, and this present talk are catered to not only pathologists but also to the clinical residents and neurosurgeon, medical oncologist, etc. And my friend Dr. Gaurav Khanna, who is my colleague at SRL FMRI, and Dr. Anila Sharma, who is a senior consultant at Rajiv Gandhi Cancer Research Institute in Delhi. Both these, me and these two friends are going to cover this whole of WHO classification in 7 or 8 weekends. And so the first class is being taken by me. This I'm going to cover the adult glial tumor and also introduce you to the basics of what minimum we should have in our lab if we want to practice the neuro-oncology. And followed by Dr. Gaurav will be taking the pediatric gliomas in the weekend after this, and Dr. Anila will be taking the circumscribed glial tumors and the glioneuronal tumors in the first week of June. So starting with the first class, all of you who, if you have any question, keep writing on the WhatsApp group which has been created, and I will keep answering as and when possible in the talk. During the talk or after, I will cover your doubts. So best is write on the WhatsApp group or in the chat box here on the Zoom. So I'm going to cover the basics of glial tumors. 1 minute. Let me just so as you know that the CNS tumors are broadly classified as astrocytomas, oligodendroglioma, ependymomas, glioneuronal tumors, embryonal tumors, meningiomas, and the mesenchymal tumors of the meningiomas, and even lymphomas. And these are the broad category of CNS tumors. I'm doing this for our clinical residents. So the basic markers which are needed in a lab for diagnosing gliomas, I'm talking about gliomas first, and the other tumors like embryonal tumors, the glioneuronal tumors, etc., will be covered, and the basic markers which are required in diagnosing those tumors will be covered by Dr. Gaurav and Dr. Anila in the respective lectures. So in the today's lecture and tomorrow lecture, we are going to concentrate on adult gliomas. So the basic tumors with basic markers which are required in a lab are GFAP, OLIG2, P53, ATRX, EMA, IDH1, and H3K27M, and ME3. These are two different markers. One is the mutation, and other is the protein, and the H3G34. These are the markers which are required. I get a lot of referrals and from many places, and I see a lot of things like S100, CD56, Synapto. lot many things being done. They are not required. What you need is GFAP, and if morphologically it is looking like a glial tumor, this is what you need and nothing else. So using these markers, let's just quickly revise how we use these markers in diagnosing different gliomas. So this is how an astrocytoma looks. You have round cells with a lot of neutrophil around fibers or glial fibers, and they show some variation in the nuclei size, few giant cells. And in this particular case, the IDH1 or 132H antibody, the IHC for IDH1 is positive. All the cytoplasms are being stained. P53, each and every cell is marked. So this is a mutant expression. And in this, the ATRX, the tumor cells are showing no nuclear staining, that is ATRX staining is lost. And these positive cells which are seen are either the endothelium of the blood vessels or some native cells entrapped in the tumor. But majority of tumor cells are showing a lost expression. So ATRX is also mutant. So this is a tumor which is IDH1 mutant, P53 mutant, and ATRX mutant. So this is an IDH mutant astrocytoma. Another IDH mutant tumor which we often see is the oligodendroglioma, which has a characteristic morphology, that is, it shows clear cells. It is again IDH mutant. P53 is not so overexpressed, so this is a wild type expression, and ATRX is retained. This is a general profile of oligodendroglioma on IHC, which needs to be confirmed by doing 1p19q co-deletion, FISH for 1p19q for co-deletion, and if it is positive, only then we call it oligodendroglioma. So these are the two IDH positive tumors or IDH mutant tumors. In contrast to IDH mutant tumor, see the IDH wild type tumor, in which again you see an infiltrating glioma, and in this case the IDH1 is not staining any cell, so this is a wild type. You please remember, when we are doing IDH staining by IHC, it is only being done for IDH1 or 132H mutation. And this mutation is the most common mutation seen in IDH mutant gliomas, accounting for almost 83 to 91% of cases. So if this is positive, then we don't even need to do any sequencing. But once it is negative, like in this case, we need to confirm the IDH mutation status by doing sequencing for both IDH1 or IDH2 mutational studies. In IDH1, in addition to this particular mutation, there are many more mutations which are present in gliomas, which can only be identified by sequence studies. And IDH2 also can only be identified by molecular testing by sequencing. We don't have any IHC available for it, but fortunately, IDH1 or 132H accounts for almost 90% of the mutation. So in this case, we have an IDH wild type tumor, which is also has a retained ATRX. ATRX is not lost. And P53 is positive in more than 10% of the cases, indicating that this is a mutation, a P53 mutant. And in such a situation, we need to do further studies because in the present classification, we do not believe in grade 1, grade 2, or grade 3 IDH wild type gliomas. So in this case, we need to go further and must do the molecular studies. Another type of a glial tumor is ependymoma. Ependymomas are glial tumor which show perivascular rosetting, and we will be covering ependymomas in detail in a separate lecture. These are GFAP positive, and in this, because all the fibers are positive, that is why the whole thing is taking a brown staining. And the difference, how do we differentiate? Here we can see many perivascular rosettes, but sometimes you may not see rosettes so clearly. In that situation, Olig-2 comes to our help. The astrocytoma and oligodendrogliomas are positive for Olig-2, whereas ependymoma or Olig-2 negative. So this is one staining which will help you in differentiating infiltrating gliomas from other type of gliomas. And the characteristic dot-like staining of a perinuclear dot-like staining of by EMA is seen in ependymoma. So this is a characteristic immunoprofile of an ependymoma. So knowing this, another feature which help us in diagnosing different type of gliomas is whether this is an infiltrating glioma or a circumscribed glioma. How do when the surgeon will come up with the information that, oh, we were able to take out the tumor very comfortably, we could just scoop it out type. And in infiltrating glioma, it is difficult to completely take out the tumor. And most of the time, in fact, all the time in pathology, what we receive are the multiple pieces of tumor, and there it is not, we are not able to say on gross examination whether we are looking at a circumscribed tumor or an infiltrating tumor. So how do we say this on microscopy? In an infiltrating glioma, there are certain features which help us in identifying that this is an infiltrating tumor. This is one such feature in which you see this is a neuron, and you see tumor cells satellite rotating around this neuron, and these are the aggregates around blood vessels. So this feature of satelitosis or perineuronal satelitosis and aggregation around blood vessels is a feature of infiltrating glioma. See, this is a feature of infiltrating glioma when you see adjacent parenchymal tissue and you see this feature. It is a short. This is the feature we look for to call it a infiltrating glioma. Here this infiltration is so intense. All the neurons are having perineuronal aggregation. In contrast to this infiltrating glioma, the circumscribed tumor will show a sharp border between the tumor and the adjacent brain. Here the adjacent brain is not normal. It is showing reactive feature, reactive gymnostocytic cells, but there is a sharp feature. This kind of circumscription does not mean it is a benign tumor. Even in some of the grade 2, 3, 4 tumors, you can get a circumscribed lesion. So circumscribed tumor, you can have a sharp border between the adjacent parenchyma. So this is an epithelioid GBM in which we found a circumscribed area. And another tumor, this is, again, you can see this is a small bit of adjacent parenchyma, and this is tumor, and you can make out there is a sharp demarcation between the tumor and the adjacent brain parenchyma. I just want to emphasize here that in brain tumors, it does not matter how much tumor has the surgeon sent to you. We must process each and every bit, otherwise we may miss such areas where which will give you very useful information. So process everything that you get, and to identify, and another reason we must process everything, the gliomas are very heterogeneous. In one area you may get a low grade tumor, while in the other area you may get high grade tumors. So this is very heterogeneous. In fact, in our institution, our radiologist emphasizes to the surgeon before they go in for operation that this particular area is radiologically high grade, and many times we get that particular focus separately in a separate container labeled as the tissue from the high grade area. So it is important to process every bit. So coming to, these are the two very important features that are needed to we should do, which are needed to recognize. That is that you process everything and identify whether you're looking at a infiltrating glioma or a circumscribed glioma. And second, the basic antibodies or markers that I have listed are required for practicing this neuro-oncology. Yes, Ashi, low-grade gliomas are also infiltrating, because the grade 2 astrocytoma or grade 3 astrocytoma or oligodendroglioma, they are infiltrating tumor. Sorry, 1 minute, please. Aditi, पापा के फोन पे कॉल करो, क्लास ले रही हूँ. So coming now with this basic knowledge to the 2021 WHO classification. So in 2007, the classification was based mostly on morphology and some immunohistochemistry. In 2016 came the 4th edition, which included molecular markers for classification, and it also introduced the integrated diagnostic approach, where morphology and molecular information were integrated together. Between 2016 and 2021, a lot of advancement took place and lot of information poured in, and we neuropathologists, oncologists, and surgeons, they got together in many meetings, and they came up with the impact articles. I think many of you must have read them, which are now incorporated into the 5th edition of WHO classification. During these 5-6 years, a lot of molecular information for a lot of tumors is now available, which has helped us in more accurate classification of CNS tumors. And this information has been added into the 2021 CNS classification. These are the broad category of the tumors which has been included in the classification. And the adult type of diffuse gliomas, as you can see, has been limited to these 3 categories, and all those anaplastic or IDH mutant GBM, all has been taken out, and glioblastoma, no IDH wild type astrocytoma grade 2 or grade 3 is seen here. and anything which is IDH wild type is labeled as glioblastoma. And all of them, and in this classification, wherever possible, the characteristically altered gene or their molecular profile has been defined and included in the classification. So this is the broad or the main lesions which are, or main tumors which are included. The gliomas are not only classified into different types, but they have been broadly categorized into adult and pediatric type. Pediatric type is again classified into low-grade gliomas and high-grade gliomas. Many and the circumscribed astrocytic tumors have been grouped separately with their defining molecular markers. And glioneuronal tumor has addition of many new entities, and ependymal tumors have been redefined and reclassified based on their molecular profile and their site. Embryonal tumors have been in 2016 also, their molecular profile showed a remarkable change, which is again is continuing, and a few new entities have been added, which will be covered in the respective lectures. So these are the the main alteration in the classification will be covered along with the each group that will be taken by either Dr. Gaurav, me, or Dr. Anila. The second major change which has happened in the CNS tumor is their grading. A lot of theory is being discussed in the book, and which is for the consumption of the pathologists who are practicing it. But basically, three main changes which has happened. One is the tumors are being graded within the tumor types. For example, we don't use words like anaplastic astrocytoma or glioblastoma, IDH mutant. We use grade them as astrocytoma, IDH mutant grade 2 or 3, or astrocytoma, IDH mutant grade 4, depending upon the diagnostic criteria which needs to be fulfilled. And the second change which has happened is, instead of using Roman numericals, we are using the Arabic numericals, that is 1, 2, 3, 4. And this is how, because most of the non-CNS tumors use these numericals, so to unify CNS tumors with the other non-CNS tumor gradings, this has been used. And another thing is that the mistakes made in putting one less or one more stroke is more common than using the numerical. So we now use 1, 2, 3, 4 like usually we use in our day-to-day practice. And the major change which has happened in the grading of CNS tumor is combining the histological features with the molecular grading, especially in gliomas. So the combined histological and molecular grade for IDH mutant gliomas, grade 2 and 3 should be tested for CDKN 2A and 2B homozygous deletion studies. If they are detected to have this deletion, it qualifies for being diagnosed as grade 4 astrocytoma IDH mutant. And for IDH wild type, as I have already said, we don't believe in, or the WHO does not classify IDH wild type into 2, 3. We once you see a tumor which is IDH wild type, it has to undergo a molecular testing for these three markers. If any of these markers is positive, even if the marker is not found, or you don't have the facility to test for these, it has to be treated as grade 4 glioblastoma IDH wild type. But remember, to call a tumor IDH wild type, we need to do the sequencing testing for making sure that it is a true IDH wild type tumor. Because we do not have anything to test for IDH2 mutation other than the molecular tests. So if any of these three tumor is, if any of these three marker is positive in any tumor, it qualifies for it to be called as glioblastoma IDH wild type grade 4. So how do we do this? How does this help us? So let's see some cases. So first is a 46-year-old woman who was operated for left frontal high-grade glioma. Now she presented with a recurrence, a post-surgery and post-RT, and at now the radiologist suggested a high-grade glioma. And on operative findings, she had a soft suckable, moderately vascular tumor with a cyst. So our neurosurgeon who are attending this class will tell you what does it mean when you write soft suckable, moderately vascular, and cyst present, what it means. So this tumor was a cellular tumor. You can see it has many giant cells, a lot of pleomorphism. And it showed endothelial proliferation. I think I also had a mitosis in this. Shows some necrosis and some more endothelial proliferation. So as far as morphological evidence for calling it grade 4 is concerned, it is fulfilling those criteria. That is, you see necrosis and you are seeing endothelial proliferation. And the Ki67 labeling index was so high, it is about 70 to 80%. So we are in no doubt that this is a grade 4 tumor. And this tumor showed Olig2 positive, and ATRX is lost. All these positive nuclei are the endothelial cells and the native entrapped cells. The tumor cells are negative. That is, it is a mutant ATRX. Hello? Hello? Are you not able to listen?
Ma'am, you are audible. Continue.
Yes, you are audible.
So the IDH, this tumor is IDH mutant and P53 mutant. So this is as we are now doing CDK and 2A2B in all our IDH mutant gliomas. So this case was showed homozygous deleted. Homozygous deletion of CDK and 2A2B. So, so in this case, it was not required to call it a grade 4 glioma, but because it already has the endothelial proliferation and has necrosis. So this was simple. So we use integrated. If we put this into an integrated diagnosis, this is a left frontal lobe glioma, which is an astrocytoma, IDH1 mutant. Histopathological diagnosis was astrocytoma, CNS grade was 4, And the molecular information of this tumor was that this is an IDH1 mutant by IC, P53 mutant, ATRX mutant, and this is a CDKN2A2B homozygous deleted by fish. So this is the complete integrated diagnosis, which is for this tumor. This is what is recommended in present the recent WHO classification to put all the information in an integrated fashion. So in contrast to this case, let's see another case in which this was a 34-year-old male who presented with the recurrent seizures for 2 months with left-sided weakness, and on radiology showed to have a right frontal high-grade glioma. The operative findings were also suggested areas of necrosis, again indicating that we may be dealing with an high-grade glioma. So we received the tumor, which on morphology, as is seen here, is not so cellular, but in another area it was very cellular. If you see this, these are small round cells with occasional larger cell. These cells are not showing any nuclear atypia or nuclear anaplasia. In contrast to this, where you can see they are more vesicular, chromatin is clumped, and you do see many mitosis here. So this is the high grade area. 1 minute. Do you do CD in all IDH mutant morphological grade 4? Yes, we are doing to standardize our test, and because we I will talk about CDK in our IDH mutant lecture tomorrow. This is another area for discussion. So this tumor was 1 minute. So this is the tumor which is predominantly low grade and some small focus of high grade. And this was ATRX mutant, IDH mutant, P53 mutant, but the key in the cellular area was also not very high. It is 2 to 3% or even less. So in this case, we said that this is a histomorphology favors an astrocytoma, IDH1 mutant, and on WHO CNS 5 grade was 2 or 3. There was no endothelial proliferation and there was no necrosis seen. So in this case, we graded the tumor after we got our CDK and 2A, 2B deletional studies or homozygous deletion studies by fish. And this tumor was found to be homozygous, showed a homozygous deletion of CDK and 2A and 2B, making it a grade 4 astrocytoma, WHO grade 4. So this is how the integrated morphological and molecular information has to be put together in according to our new WHO. So this was an astrocytoma, which was IDH1 mutant and CDK and 2A, 2B homozygous deleted. So making it a WHO grade 4. And all the molecular information has to be put together. So this is how the molecular, coming to IDH wild type cases. IDH wild type, so let's see this example. This is a 63-year-old man who presented with seizures for last 4 months. On radiology, he had a left frontal SOL, which was radiologically low grade. And even the operative findings suggested a low grade glioma. So this is the tumor, multiple hits, again an infiltrating glioma. cellular, no necrosis or endothelial proliferation seen. All these vessels are thin, delicate. So in this, the IDH is wild type, OLIG2 is positive, ATRX, almost all the cells are positive. So this was an IDH1 wild type glioma. P53, more than 10% cells positive in making it a P53 mutant. Ki67 labeling is so low, only these 2-3 cells are positive. So in this case, since it was an IDH1 wild type, we said that this is a astrocytoma, IDH1 wild type, to be graded after the molecular profiling. So we waited for the molecular profiling to report to come, which takes about 15 days. And we found that MGMT promoter methylation was detected. IDH1 mutation was not detected. IDH2 mutation was also not detected. So making it a true IDH1 wild type glioma. One P19Q codeletion was done by fish and it was negative, but this tumor had EGFR gene amplification by fish, and TART mutation was also present in this by pyrosequencing. So out of the 3 markers that we need to do for identifying grade 4 gliomas in IDH wild type tumors, 2 were positive in this case, making it a grade 4 glioblastoma. So the integrated report which went out showed glioblastoma, IDH wild type, EGFR gene amplified, and TERT mutation detected. And all the molecular features which were seen in this case were listed. Another important aspect which is covered in this classification is use of a postfix of NOS and NEC that is not otherwise specified and not elsewhere classified. These are the 2 terminology which have, or the postfix has to be added. And let me just explain to you how to use these 2 designations. So NOS is not otherwise specified. That is, there is lack of necessary diagnostic information, which can be of any type, but most often it is the molecular information which is not available. And lack of this information may be because of any reason, whether you are unable to do the test, whether tissue not sufficient, whether the tissue, the test was done but failed and no retesting is not possible. For whatever reason, you are not able to give the required information to fulfill the specific criteria of diagnosing the WHO entity. And this is important that you do this because it alerts the medical oncologist that a full workup was not undertaken because of whatever was undertaken and was not successful for whatever reason. We were unable to do the provide the required information to fulfill the diagnostic criteria of a WHO entity. So see, this is a 35-year-old man who presented with recurrent right frontal glioma. He had the tumor operated twice before and now presented with a recurrent tumor. So this is the tumor. As you can see, moderately cellular, and you can see that each has a very clear-cut oligodendroglial morphology, the fried egg appearance, the chicken wire vasculature, very delicate vasculature, calcification. all this pointed that it has an oligodendroglial morphology. The olig2 was positive. ATRX is retained. This is IDH1 mutant and P53 is wild type. So this was a right frontal glioma, which has histopathological classification was it was an oligodendroglioma, which grade 2, WHO grade 2. The integrated diagnosis was oligodendroglioma NOS. The molecular information provided that this is IDH1 mutant, ATRX retained, P53 also, wild type by IC, and 1p19q co-deletional studies were not performed, and because the patient was not willing. In our setup, we have this limitation that we can only do if the patient is willing to pay for the test. But I'm sure in medical colleges, this limitation is not there. So because of that reason, we called it an oligodendroglioma NOS, to be confirmed by 1p19q co-deletional studies. So using the NEC designation, it indicates that the necessary diagnostic testing has been successfully performed, but the results do not allow the specific WHO class diagnosis. There is a mismatch among the clinical, the radiological, histopathological, or immunohistochemical stain finding and or molecular findings. So NEC alerts the oncologist that the tumor does not conform to the standard WHO diagnosis despite the case having received adequate pathological workup. So let's understand this. So this is a case where 42-year-old woman had emotional instability, and she had a right frontal low-grade glioma, and we received the multiple bits, and it showed again a very oligodendroglial morphology, subpial aggregation, perineuronal aggregation, and tumor cells were also clear cells. Okay, this is just to tell you that this kind of a star-shaped GFAP positivity indicates these are reactive astrocytes. The tumor GFAP positivity is like this. So this is a GFAP positive, OLIG2 is positive. But this tumor, even though we were thinking that this is an oligodendroglioma, so it was IDH1 negative. We repeated again and we found that this was IDH negative. And the ATRX was retained, P53 were clearly wild type. So this is a, we waited for, we thought maybe this tumor has an IDH2 mutation. So we waited for our molecular information to come, and we found we had a surprise here. So this case was the histopathological diagnosis was oligodendroglioma, again grade 2. And the IDH1 and IDH2 mutation was not detected. So this was actually an IDH wild type tumor. And we had a further surprise in this, that this was a 1p19q co-deleted, full arm co-deletion was detected. And this also had a TART mutation, which the TART mutation again is a marker of oligodendroglioma. So this tumor had both the markers positive for oligodendroglioma, but this was an IDH wild type, and WHO does not classify oligodendroglioma IDH wild type. So we labeled it as oligodendroglioma NEC IDH wild type, 1p19q co-deleted, and TART C228T mutant. So this is an entity which is, this is a recent case, And I was trying to find out whether there is any case anywhere where they do classify oligodendroglioma when two important markers are positive as oligodendroglioma. But no, I have not found. And maybe in this case, what we require to do is the methylation profiling of this tumor. So, as I spoke of the methylation profiling, we know in this recent WHO classification, as we know, over the time, many new technologies have come in the diagnosis of tumors, and they have had their own impacts, from light microscopy to IHC. Then a variety of molecular technologies came, and each time a new technology came, especially when the sequencing and NGS came, we thought that, oh, this will give us a complete diagnosis. But this has not happened. Each technology has helped us to a certain extent, and but still a lot needs to be done, and a lot need to be discovered for categorizing, for profiling all the tumors in CNS. But each technology has found its own corner and fitted into that corner and helps us in to some extent. But our journey to discovery is still going on. And in this line is the methylation profiling, or methylome, when we do the methylation profiling of whole genome. And this is the new kid in the, what do you say, new kid in the school, which is now the thing. Everybody is trying to use methylome profiling to identify and classify the CNS tumor types and subtypes. In the present book of CNS, we do have a chapter devoted for methylome profiling of CNS tumors. I personally do not have any experience of methylome profiling, so I have not covered that part. Maybe I will request someone who has experience in dealing with methylome profiling do a class for us in this series. If I am able to get such a person, I will announce it in further classes. And another important point, which is covered in the introductory lecture or chapter of this WHO classification, is the standardization of mitotic counting and standardization of key 67 labeling index. When we say per high power field count, if it is a big microscope which has a larger high power field area, you may give a higher count, in contrast to a person using a microscope with a small viewing area or small field of high power field. So then they will count less. So they have given a table in the book how to standardize the per high power field depending on the area of your high power field, 2 millimeters square. And using that table, we should standardize our key labeling index counting and the mitotic mitotic figure counting. So use that table. That table is available not only in this WHO book, but it is available in many of the test books. So this is very important, that our key count labeling index counting and the mitotic counting is standardized. Then this book, a new book has many, in fact, 22 new entities which have been added in this classification, and each of these 22 entities will be discussed in the respective classes. As many, we would like to show you also wherever we have a case, but because many of these we may not have, because these are rare cases type of tumors, we may not have all the cases to show you. So thank you very much for listening to me. Yes, Kunal, new kid in the school or block, same thing. क्या हुआ? चैट कहाँ चला गया? So no questions? Wasim Kitab has raised his hand. Can you ask your question, please? We can unmute all of them. Oh, we will cover the tumor. Don't worry, Dr. Chitra. I was on time. Yes, there is a cutoff which I'm going to talk tomorrow. You know, for mitosis count, before all this key index and everything came, there used to be a time when we used to say that all the tumors which have a mitosis of more than 2 in the whole tumor is going to behave poorly than those tumors which have a mitosis of less than 2 in whatever number of sections that you have examined. So so now we say that especially in adult gliomas, if you see even a single mitosis in a small biopsy, it qualifies it to be upgraded from grade 2 to grade 3. And especially for key, there is the grade 2 tumors usually show less than 4% of key. Grade 3 is 4 to 10%, and anything more than grade 4 mitosis is not so important, as is the presence of endothelial proliferation and necrosis. But if you see a case where key is like I have shown you 50, 60, 70% or anything more than 20%, even if you don't see any endothelial proliferation or any necrosis, it is you are dealing with a grade 4 tumor. That is why when you don't see any of these, any of the 2 features which are required morphologically to be diagnosed as GB or grade 4 tumor, we do these molecular markers. And once we, invariably in IDH wild type, they are always, there is 1 or 2 markers which are positive. making it grade 4 tumor. Yes. If morphologically glioblastoma but molecular profile does not match, do you still? Of course, once you have seen endothelial mole proliferation necrosis, you don't need anything. Yes, we need to not only do the molecular profiling. There are a lot of things which need to be done before, because what we are looking for a target to treat the glioma, and for example, I give you an example that in children and a young adult, if you see a glioma, which is then you must include MSI testing, because these tumors are associated with mismatch repair gene mutations. And if we find MSI mutant, we have a target which can be treated here. So the molecular testing is not only for diagnosing, but for finding a target to help treat these patients, because as we know, we don't have many options for treating glioblastoma. Oh, no. S100, SOX10, etc. are not needed. IDH, ATRX, P53. Oligo has to be IDH mutant, ATRX retained, P53 wild type. TERT mutation in oligo does not make it grade 4. TERT mutation in oligo makes it oligo. Grade 2 or 3 will be grade 4. Oligo, we don't still call it grade 4. We will do oligo tomorrow, and we will cover, I will tell you the grading of oligo. Oh, we will be doing IDH mutant effect prognosis. IDH mutant, we will do this tomorrow. This is a long talk, because IDH is a mutation, methylate the DNA extensively, and that is the pathogenesis of the IDH mutant gliomas. I will talk about it tomorrow. For gliomas, what you need is GFAP, OLIG, ATRX, P53, IDH, and now must include, because more and more we are doing histones, that is H3K27M. It does not, I mean, age is no bar in this. Even adult and old people are also getting H3K mutant gliomas. So I feel that we should now include routinely H3K27M or H3 G34. Both are available on IHC. We should include them in our routine testing of gliomas. So these are the only markers which are required. We don't need S100, SOX10, or Synapto, or any such marker in diagnosing gliomas. Oh no, IDH mutation has nothing to do with 1p19q. I will do the explanation tomorrow in IDH mutant gliomas. You know, IDH mutation goes in two ways. One, it becomes astrocytoma after ATRX gets mutated, or P53 mutation, and when 1p19q co-deletion and TERT mutation becomes the oligodendroglioma. We are going to do this tomorrow. If there is discordance between IHC and NGS, which one should we follow? We should follow, I mean, the book says, and if there is a discordance, the molecular is to be believed. But I feel that we must retest both IHC and NGS before we believe any of them. And we have to make sure the quality of the IHC and the quality of NGS which has been performed. Quality, making sure the right controls and right calibration and right validation has been done to use both these technologies. I think we have shot above 10 by 2 minutes. I think we can stop here and we meet again tomorrow. Okay, good night, everyone.